I would like to start with taking you to two patients' case histories that underline my story. Of course, we have Dave, but I'm coming out of my own practice. And the first one is a patient, it's a man now 64 years of age, who was diagnosed with superficial bladder cancer at the age of 62. And he had actually two choices to make. But he started with the one proposition of treatment that was done by his community urologist, which was treating his bladder with installment of chemotherapy in the bladder. But there were a lot of doctors involved in his decision-making, including 6 in his own family. And they said that he should go for a second opinion to the most famous urologist in the Netherlands. And he came there, and this man said to him, well, you come to me, you ask me for opinion, I think you've done stupid, get rid of your bladder, do a cystectomy. And then he said, well, I trust my community urologist, and I would like to do that then at his place. And then this physician said to him, well, you know, if you rent the golf clubs of Tiger Woods and give it to an ape, he will not play like Tiger Woods. The result of this consultation was that this man was anger and anxiety, and he still has anger and anxiety. Second case history. A female breast cancer patient, she was treated for breast cancer at the age of 42, and she had an option for treatment, 3 choices to make. An important one was the choice actually to go into endocrine treatment. I will not go into details, which would make her a postmenopausal woman at the age of 42 with all the complaints and toxicity involved. And she encountered in the community hospital a lot of very much involved physicians, a radiologist, a radiotherapist, a surgeon, a medical oncologist, and they all had a different view and went into shared decision-making with her, explained all the pros and cons of the various treatments, but she was totally confused. She went to a psychiatrist to help her to make into decision-making, and again, she was not very, solid in her decision, and she came to me, and she actually asked from me to make a decision for her. Okay. The result of all this consultation and shared decision-making actually was also confusion and anxiety. Well, that set the tone, right? Okay. Before I go, I think this is an audience, and not all of you are involved in cancer, right? So I would like to say something about cancer in general. This is 1960, it's close to the time that Kennedy was murdered, actually, but when it came to conquer cancer strike back. And it was said at that time that if you would give enough money, in 2000, this would be a curable disease. However, as we know by now, it's still one of the top 10 causes of death is cancer, whereas it was pneumonia and tuberculosis at that time point. And if you look in the Netherlands, it has become number cause 1 of death since the 2008, so it still is there. And we are faced in the Netherlands, we just go from the United States to the Netherlands, with a sharp increase in the number of patients that will be diagnosed with cancer, which is an increase of 42% in 2020. And again, we are also faced, because as a physician I do some things very right with my treatments, so we are also faced with an increase in the number of people surrounding us that have been treated for cancer or are still being treated for cancer. So this is a really, really great problem that we are faced with, a challenge we are faced with. And it's due to a lot of things: increase in obesity, increase in alcohol consumption, increase in still cigarette smoking. But the main cause is that we're all getting older because we're not dying of pneumonia, cardiovascular health. And it's disease of the elderly. Another thing that we are faced with is that cancer is not one disease anymore. Dave already said to you. And also breast cancer is not one disease anymore. It's at least 10 different types of disease with 10 different types of treatments. Also with lung cancer, very deadly disease, we now know it's not only one disease, it's many more kinds of diseases due to the fact that cancer is a genetic disease and we are much more aware of what genes are playing a role in cancer development. So what is going on here? From one size fits all treatment to everyone the same treatment as a physician, we go to the patient being his own or her own model. We have now nearly 900 medicines, and I'm not talking even about the possibilities of treatment with surgery and all kinds of radiology techniques, but we have more than 900 medicines that now are being developed against cancer. But we are treating a disease of the elderly, and what we also faced with, and I think Dave excellently showed us that we are faced with an elderly population with comorbidity, with a little hypertension and a little diabetes and a little infection or arthritis. And what we've seen here with the research on the women with breast cancer, that with increase in comorbidity, this is a comorbidity index, that the chances of dying are nearly doubled. So what we are faced with in our future, and actually as we start today, as I'm talking to my patients just in your lunch, we have numerous possibilities here in diagnostics and treatments. And the most fundamental question we are faced with, all of us, is what will be the best treatment, when to apply, at what moment, for what patient, in what context of comorbidity, of society context, or family context. And another thing, and you elegantly addressed it also, is that I said to you 4% of our Dutch population has been treated with cancer in 2020, or at that moment is treated for cancer, but we're trying to get it more like a chronic disease. You have heard it all over the papers the last weeks. But chronic disease is stage 2 to 4, and the treatment costs are increasing at that time. And it has been notified in a lot of our medical papers what we're going to do with the economic burden of cancer survivorship. And what the NIH have seen so far, that for all the common cancers, breast, colorectal, lung, lymphoma, prostate, that by 2020, 2025, there's a sharp increase in the costs of treatment, and this has been said in the Volkskrant, one of our Dutch papers, Dave, how the cost will be in the United Union. So there are a lot of things playing around here in the field of cancer. And I think that we can only face all these aspects by doing it together, and also by not let the physician alone to make the decisions, but join forces. And I would like to go for shared decision making with you briefly. The importance of it has been demonstrated here. What went wrong? What goes wrong if you don't explain to the patient why she or he choose a treatment? This is one of our most important papers in medicine, is the New England Journal, and it said here that patients' expectations about effects of chemotherapy for advanced cancer, that they're receiving chemotherapy for an incurable disease. They don't understand that it's incurable. But if that would have been explained to them, they probably would have made other choices. Well, the ASCO, the American Society of Clinical Oncology, is our professional organization, has stated in their future document for 2030 that a significant shift in doctor-patient relationship will occur. Also thanks to Dave and all his activities. But it's stated here also, it's stated here, and I will read it for those in the back. Although oncologists will give up a measure of control in the relationship, they will have much greater confidence that the treatment plans truly reflect their patients' wishes. And already there has been many conferences on shared decision making. One in the Salzburg Global Seminar, and I have it here in Dutch. But it said here that we ask physicians to agree with the ethical point of view that important decisions should be taken together. It's a two-way traffic. And also we ask patients to really explain what their cares are, what their views are and what they would like to know about treatment options and disease. So it's again stated everywhere. Still, we have my case history of bladder cancer and breast cancer. This is our Dutch Foundation for Patients, NFK. Cancer, what are doing, take your own control, take it in. So there's a lot of attention for that, with cards being depicted everywhere. You can take this card and you can control your own consultation. And on the National Cancer Day, on the February the 4th of next year, 2014, the Zorgstandard Kanker will be presented. And one of the main sentences in this document is that both the physician and the patients are having their own competences that are, synergistic additive for self-management and also for making the best decisions in doing treatments, but also in knowledge. So there's a lot of attention also in the Netherlands about this topic. There was a question about reduction in costs about shared decision making, and it's funny that there has been done a study on family physicians where they asked patients to help make decisions about the use of antibiotics, and they make like a trial in that, and the conclusion was that to enhance patient participation led to fewer patients deciding to use antibiotics, and it had not any negative outcome on their health. So it could also contribute to cost reduction. We were talking about prostate cancer screening, because one of the things that we as physicians are faced with is that on one side, the community asks of us to have more time for patients, to spend more time with them, but on the other hand, we are faced with things that the society wants from us, but also increase in production, so do more patients for the same time, which is a rather conflict of interest if you look from a general view. What has been seen with the prostate cancer screening discussion, where the scientists are not really agreed upon the validity and of the use of it. What you see here, it's a very, very relevant paper, which has also been presented many times, is that a lot of physicians are just allowing patients to go for the screening, whereas if the men would know what would be the morbidity and the mortality, they probably would not have agreed upon. But also there are, would you like to call it perverse? I don't. But there are some things where physicians are feeling pressed to do several things, and that is time constraints. It takes much more time to talk with the patients and to tell every kind of view and scientific evidence there is. Fear of being sued if they make a wrong decision, and the complexity of the subject of screening, pros and cons. And in addition, there is no reimbursement for doing a really shared decision-making consent, and there is well reimbursement for prostate cancer screening. So again, probably perfect sign, but it's there. A very nice paper has been published for the Medical Oncology Society about shared decision-making, about collaborative conversation between patients and clinicians, both with their expertise, and the patient should be able to provide his or her preferences so that they can reach a mutually agreed upon plan. And this should be the steps taken into that. Now, if you remember the case histories that I told you about, if you look in these steps that should be done, describe options, risks, benefits, and uncertainty associated with options, elicit patient preferences and values. The man with the bladder cancer, none of this was done. It was not asked what his preference was. He was really having trust in his own community urologist. He didn't want to have his bladder removed. Even though his family asked it to go for a second opinion, he himself didn't read any literature. He just wanted to make a decision being made for him by the scientist and the physician he trusted. This was not done by the man who said that you could better golf than Tiger Woods. With regard to the woman with breast cancer, there were too many options for her And actually what she asked from the physician is to make a decision for her out of all the things that are known. She had her own pros and cons, but in the end she was insecure by all the physicians that said, it's your decision. At the end she would ask from us, you're the expert on breast cancer, please help me to make the decision and then let me just rest and just take whatever I think it's worthwhile to do. So again, these are steps that we should make ourselves common in our practice. So one of the things I think is that cancer is a multidisciplinary disease. There are many, many doctors involved. And if you have, like in this case history with breast cancer patients, many views also can add to uncertainty. So you have to make a process in which decision making finally ends to one decision. Insufficient expertise. I think what we are faced with in the Netherlands is that all hospitals are doing cancer. Is that still allowed? With all the things that we are faced with, 900 medications that are in development, so many more diagnostics, so much more complex diseases. How are we going to face with that? Time restraints, and I come back to that later. I think there is, and I would really like to have that, and many of my physicians who also do research would like that, to have patients also help us to define our research program. The only way that we can proceed in having a better outcome in cancer is by doing studies and by involving patients. In the Netherlands, a maximum of 10% of patients is participating in trials. But they could help us also. They could help to explain the importance of doing clinical research. And some of the issues are put on this slide, but because of time, I will continue. But it's important to also make a shared effort there, as it is in education. At symposia and conferences, and especially in the United States, if we have our largest breast cancer conference over there are always everyday table sessions, discussion sessions with patients involved. Not all physicians like that, but it's important because only the two of us together can make a right decision and also can help the cancer go forward. We have done a lot of that, borstgesprekken, which has been introduced in the UMC Utrecht, which is actually very nice, where we have physicians that are not the treating physician of the patients together in one room, and both of them can explain to each other the uncertainties they're confronted with, the things that they encounter in their practice, in their clinical meetings with patients, and it helps physicians to understand how patients look at them. They should be involved here in the Netherlands in defining the criteria of quality control. As Dave said, what's actually quality of care? But we could ask them the things that we think are important. Do you think that that's important? Organization of care path, concentration of care. Are we going to 20 centers doing oncology in the Netherlands, which has been stated a lot of, are we going there? So what will be the best way to do that? And societal implications. The funny part is that at our last meeting, this ASCO, the American Society of Clinical Oncology, which is a conference with 40,000 attendees, stated last year 2 studies. And it said that patients would like to be involved in discussions about money and discussions about how we're going to proceed in the plethora of things that could be done in cancer care. But that only a minority of clinicians are willing to discuss anything of costs into care. So what are the needs for physicians and empowerment through patient engagement? I think there are 3. We need to collaborate, we need to educate, and we need to redefine. I discussed with you the care path, and I think that patients should be involved in the ways of prevention until the end of life care. In research, education and training, and societal decisions about how we're going to spend money in this very, very increasing number of patients that we will be faced with. The 2 of us need to be educated. How are we going to handle the very educated patients? My own clinic is primarily based on second and third opinions. And as I said several times, the major part of the questions that I are faced with from my patients is this the treatment that's the best all over the world? And why did the doctor choose that treatment? It's just like giving explanations about what has been done. And in a very few moments, I think it should have been another way. The majority of the time is just that I take the time to explain things to them, to explain the options there. It's seldomly that the treatment has really gone wrong. But we need to educate our physicians and our coming physicians how to handle and how to look into the one is sitting next to you and on the other side and their families, and to explain to them what are the options. And we also need to inform the stakeholders, in this case also insurance companies, decision makers, and also other kind of stakeholders. To do so, I think, as Dave again elegantly showed us, we are faced with a very different time of physician-patient interactions. Faced with the plethora of things that we're going to do, and the availability of treatments and options, faced with a lot of patients with comorbidity, faced with patients that are very into internet consultations, we have to redefine our process of consultations. And what we should probably do is to also reimburse a first and a second consultation in another way than the consultations afterwards. Because what patients need is, when they start treatment, to have a very extensive explanation of what is the treatment going to bring them, at what toxicity, so that they can properly decide and come back to you and talk again. And then afterwards the consultations could be shorter or could be done by e-health. So I think we have to refine the process of consultations. We have to look into expert networks, because if breast cancer has 10 subtypes, then you really need to be very expert on breast cancer, and you cannot also be an expert on 20 types of lung cancer. You cannot be an expert on 40 types of colon cancer. You really need to have expert networks that can be consulted by patients, but also can be given together by patients, also on internet. And as I said, the financial incentives should not play a role, but should be also redefined in our change of care. And I think this is what I would like to say, and I will keep it shorter than I thought, but this is it for this moment.